Good morning, everyone. My name is Elizabeth Keating Matthews. I am the Program Director of Research Administration at the Florida Institute for Child Welfare. And I'm so excited for you all to join us today. Dr. Boel-Studt and her colleague Robynn Baker are here to share their findings on a project that they've been working on for almost 2 years now. So very exciting for them. I want to do a little bit of housekeeping, and then I have a small introduction, but then I'm going to pass it over to Shamra and Robynn so that they can really take it from there. So for our small administrative things, everyone who's on the call today, you are automatically muted and your camera is off. If you would like to communicate either questions or comments, please use the chat box. If there is something that you feel like you want to say verbally, just use the raise hand feature, and my colleagues, Juliana and Bethany, will unmute you. They are our behind the scenes support today, so if you have those technical issues, feel free to message them. They'll do their best to help you. Like I said, we are recording. At the conclusion of the webinar, we will share this widely. You will get a follow-up from us, so you will have the recording and the materials. And of course, if you want to dive deeper, you're more than welcome to reach out to Shamra and Robynn directly to discuss their work. So to level set for everyone, I saw the registration list. I love how many people are here in such diverse backgrounds. And I just wanted to make sure that everyone was joining the webinar with a little bit of background of who we are and the type of work that Shamra does. So the Florida Institute for Child Welfare is a research institute housed at the College of Social Work at FSU. We are legislatively mandated. We provide research, findings, recommendations directly to the legislature. And then we also have a programmatic side where it takes our research and other research from around the country and implements it into child welfare workforce programming. Many of you are probably a little bit more aware of our Growth Center and the programming that we put out. So much of what you see forward-facing to the public is our Growth Center, but we do have a really strong research team here at the Institute, and then we also have a network of affiliates across the state. So Shamra is one of our affiliates. She has been with us for many, many years. I tried to go back to see how long she's been with us, and I don't even think we have documentation that shows how long you've partnered with us. So as always, we really appreciate you, Shamra, and your support and all of the hard work that you do for the Institute. A little bit about Shamra specifically is she is an assistant professor at FSU's College of Social Work. She is also the director of the Institute for Quality Children's Services. I'm sure she will speak on that a little bit more. And overall, she has had 20 years of combined experience in practice, training, and technical assistance, research, and evaluation, spanning the child welfare system, children's mental health, and juvenile justice systems. So just a wealth of knowledge that she comes and brings to the table for the Institute and for Florida as a whole. Alongside her is her colleague, Robynn Baker, another huge role in this project. I don't want to speak too much for Robynn because I know she's going to share her her impact that she has had on this project. But from the inception, she has stood by Shamra and worked on this all the way through. So very happy that Robynn is here with us today. What makes this project a little bit more special is that Shamra was the recipient of our 2024-2025 Priority Research Award. And that award was focused on supporting parents and caregivers. And we included all types of parents and caregivers in that topic. So we're talking about mothers, fathers, kinship caregivers, foster parents, and really anyone who is providing care to a child that's impacted by the child welfare system. So her study, as you can see on the screen, is the Caregiver Journey, an in-depth multiple case study of families' experiences with accessing residential care for their children with high-level needs. So again, thank you all for joining us, and I'm going to pass it over to Shamra.
All right. Thank you so much, Elizabeth, for the wonderful introduction. We're actually going to start things off. Robyn is going to lead us off. So Robyn, you, who was, by the way, she was the co-PI on this. And I feel like if we're talking about who walked alongside who, I think I walked alongside Robyn. So she was a major force in driving really the need for this study, and also very actively involved in coordinating all of the data collection, helping. There wasn't any part of this that she wasn't involved in. So I want to make sure that credit gets put where credit is due. So Robyn, go ahead and take it away.
Okay, thank you so much, Shamra, for that lovely introduction. And thank you all, everybody, for being here. I just want you to know this is my second presentation ever. I am terrified. This is not my cup of tea, so I apologize if I step all over myself. It's a very important project to me, though. I'm an advocate for high acuity children and their families. I'm what you would call a reluctant advocate. I didn't want to be in this position. I came to it because it actually came to me. When my son was 3 years old, he suffered a traumatic brain injury during a surgery. And the effects of that were physical disabilities, cognitive disabilities, and really extreme behavioral disabilities. When he entered puberty, those behaviors escalated beyond what I could have managed. Despite every lower level of care that we did, he was continuing to get worse. Brain injury meets puberty kind of thing. It was life-altering. And I had to make one of the most gut-wrenching decisions a parent could ever make after going through him, a special needs teacher trying to press charges against him, and just a whole set of circumstances that I finally realized that I could not keep him safe, nor could I keep others safe. Made the decision of putting my child in residential care. I was naive. I thought when I made that decision that, the hardest part's been done. I've realized he needs this help. Now let's get him help. Unfortunately, that is not what happened. The experience was emotionally and physically exhausting. I felt like I fought a battle at every turn, navigating systems I did not understand, advocating services for him, trying to get people to listen to me and protect my son and protect my family at the same time. And it left me wondering, what are other families going through? I had people like Dr. Boel-Studt, who was also a friend before she became a colleague. I had teachers helping me. I had resources that some other people don't get because I was a nurse by trade, and I did have social workers as friends. So that left me wondering, what about the ones who don't have the support system that I have? Dr. Boel-Studt, she walked every step of this journey with me. So many phone calls, so many emails, so many times I've called her, and I don't know what else to do. And that left me in her late night pondering, what are the other families going through? We asked these deeper questions about these caregivers' experience. And it turns out that's how I ended up as an advocate for children and families with the high acuity children. And so this study is not just about data. It's more of a reflection of lived experience. It's about understanding the emotional toll and the systemic barriers and the resilience of these caregivers. Because I'm going to tell you guys, these caregivers are some of the most resilient people that I've ever met. They really go through the pits of hell to help their children and continue and continue and continue. And I'm honored to share this work with you today, and I hope that it sparks some more meaningful conversations and change for families in Florida and maybe beyond. So All right, let's get. Oh, Shamra, can you switch the slide for me? Oh, no. There we go. So therapeutic residential care, let's define that really quick. According to the International Work Group of Therapeutic Residential Care, therapeutic residential care involves the planned and purposeful constructed multidimensional living environment designed to enhance or provide treatment, education, socialization, support, and protection to children and youth with identified needs. So they're not just providing them a place to live, they're providing them a safe place to live with specialized form of care designed to support those children who have those complex needs, which often stem from trauma, neglect, or behavioral challenges. This isn't a new way of practicing. This is something providers have or should be doing all along. This is just a clearer and more defined and accurate encompassing the definition. So, therapeutic residential care, it's vital for stabilization and treatment of a subset of children with high acuity special needs. We do understand there's many children who the lower level services are absolutely appropriate, but there is this subset of very high acuity children that do need stabilization. And it's stigmatized as an intervention of last resort. And I think that's one of the reasons why families are in such crisis when they come needing this kind of help, is because the thought of placing your child in residential is, number one, there's guilt and shame that comes along with it. There's a lot of policies out there that are decreasing the therapeutic residential, like the Family First Preventive Services Act of 2018. That leads to less funding for the therapeutic residential and shorter stays when funded. And that really bothers me, that why are we even putting these kids in a program if we're not going to complete the treatment? What's the benefit of that? Why would we even begin a treatment and not finish it? So that's one of my real pet peeves about some of the thing about the shorter stays. And then, of course, we have fewer therapeutic residential centers, and we found that the more higher acuity the kid is, the fewer options are available. If they are intellectually disabled, fire starters, children that sexually perp, all these kids are left in this area where there is nothing available for them in the state of Florida, which leads to really significant services gaps. And we do recognize that reducing utilization of therapeutic residential there's children that just don't need it, but it exacerbates issues who need access for it. And it's not just for the children, it's also for the families. So they can also benefit from hopefully rebuilding this relationships with their children, because that's one of the things that happens is the family relationship is so fractured because you're so exhausted of dealing with this really high acute child. So they're faced with the caregivers are faced with a bunch of challenges, the emotional stress and guilt, which, as I touched on, I didn't think I was going to survive that guilt. It's just one of the most painful things to recognize that you are not what's best for your child. There's stigmas and barriers. Of course, there's a lot of judgment from people who are you just want to get rid of your child, when really these caregivers have gone through so much to get to this point to fight for their child. It would be much easier just to walk away and go, I don't care anymore. And of course, once the child is involved, there's limited agency and involvement. And then there's there's not very much preparation that comes from them transitioning out of care. And so the study advances emerging research by using a structured framework to explore the care-seeking process, focusing on the context, the child and caregiver needs, and service experiences at each stage. Overreaching aims is to elevate the caregiver voices, because that is so important, and listen to the providers who are trying to assist these caregivers so it can identify and inform policy and practice endpoints. Practice points are specific areas which their care-seeking journey, such as before, during, and after, when targeted actions can lead to meaningful changes. And I will let Dr. Boel-Studt take over.
Right. Thank you, Robin. Can everybody hear me okay? Good. All right. So I'm going to take us into our study framework as well as present the results. But first, recognizing that the process of seeking and receiving residential care is a journey, right? We wanted to find a framework to help us organize this. And so we adapted an existing framework that was developed by a researcher, Hainstock, in 2017. And so we adapted this to fit the process of care seeking and receiving in residential care. And it organizes this process into 3 phases. Pre-placement, which includes those precursors. So what was happening with the child and in that family environment prior to that caregiver making the decision that we need a different intervention. We need to seek out residential care. And then also that moves into the action of seeking and navigating the system to find residential. The second major phase is placement. So once a placement is secured, there's a period of transition, and then admission and the actual placement experience. And then that's followed by a post-placement phase. So transitioning and discharging from residential care. And then what is life like after residential care for these children and caregivers. And so we applied this framework as a way to make sure that when we're gathering information about the process, we could really pinpoint it to a specific phase. That's really important to help inform targeted, as Robin defined, impact points, which is our overarching goal. There were 6 aims of this study specific to each phase, but we can essentially summarize our aims as focus on identifying factors that led up to our caregiver's decision to seek out therapeutic residential care, to explore their experiences with navigating that system and that process of seeking out a placement, to understand what was the caregiver's involvement once a placement was secured, how did they experience that, and also examining the transition out of residential care and what did life look like following that. The nature of this study really speaks to qualitative methods because we want to get at those rich descriptions, those details. So we used a qualitative case study design. We interviewed 21 caregivers and 21 service providers. We also so our data analysis approach was deductive thematic analysis. And this just means that we organized our data analysis and the process of identifying common themes in our interviewers just based on that framework. We also use a cross-case synthesis. So this is a process of trying to find shared themes and differences across both our caregivers and providers. It's kind of like being able to bring together puzzle pieces from different stories together just so we can get this bigger, more nuanced picture. Before I get into the results, so I do want to make sure I offer some acknowledgements here. So first, the data from this study is really rich and multi-layered, and there is just no way I can get through all of it in the time that we've got. Related to that, I also want to acknowledge that, our efforts to convey the stories of caregivers are never really going to do them full justice. Even with qualitative research, there's some kind of reduction in the summaries that we offer. So we're not able to fully capture it, but we are going to do our best. And then also, I want to thank our caregivers and our providers that spoke with us and our partner agencies who jumped at the chance to collaborate with us because they too have, a passion and a mission to serve families. So, we take the families' stories very seriously, and we want to use this as an opportunity not only to listen to caregivers and providers, but to honor that, those experiences. Okay, moving into our results. First, let's talk about our sample. So we had 21 caregivers. The majority were females who we spoke with. You can see most were married. a pretty even split there of biological and adoptive parents. When you think about, you know, our sample, we tend to describe our sample as kind of among the relatively well-resourced. And this is because, as you can see, we're talking about two-parent households for the most part, but also caregivers who had some professional experience working in child services systems, either as educators, case managers, or, you know, having some role in either the disability system or the dependency system. So they kind of had that background, which separates them a little bit from who we tend to think of as, you know, our families who we're coming into contact with in the traditional sense in the dependency systems. That is important to keep in mind. The children were mostly about early to middle adolescence. We had a pretty good split of male to female children with slightly more males. The two most frequently mentioned diagnoses were autism and ADHD, but you can see a whole combination of diagnoses there and a lot that aren't included on this kind of short slide. At the time of the interview, most of the children were currently in a residential placement, and that was followed by the second largest portion who were still actively seeking out a placement. Providers were, again, mostly female. The largest percentage of them were service coordinators, and that was followed by program directors and therapists. Okay, so now to get into the results, I'm going to organize my discussion of results just following along the framework. And I'm going to center on talking about the salient themes from caregivers and providers specific to each of those sub-phases. Also, as I go through the results, I'm going to identify areas of convergence or agreement across what we were hearing from providers and caregivers. Okay, so starting with pre-placement. And within this, we're going to start with talking about the precursors, that period of time prior to actively seeking out residential care. So we found in our caregiver interviews, there were 4 common themes, very consistent here. So prior to seeking residential care, our caregivers were dealing with a combination of serious behavioral challenges, including aggression, violent acting out, physically assaultive behavior, property destruction. One of our caregivers described, you know, their walls looked like Swiss cheese. So our children were having frequent explosive meltdowns, and that if you compare that to a typical tantrum or behavioral outburst of a child, these are meltdowns that last for hours. Some children also exhibited sexual acting out and extreme preoccupation with pornography. Self-injurious behavior was common, especially among the autistic children. So we're really talking about extreme trauma and inability to regulate. Most of these children could not manage in public spaces for very long, and school was also a big problem. And if you, reflecting back on that chart where we're summarizing the diagnoses of the children, really you can see, you kind of get this picture emerging of symptoms of co-occurring mental health and in some cases intellectual disability and autism. So just a complex array of conditions coming together here. One mother, you can see on the quote there, described the complex nature of the relationship with her adoptive daughter. But this really resonated actually with, in our conversations with caregivers, is they did express this deep commitment to these children. So this mother, she says, sometimes she can be so mad 1 second, and then next it's like, I love you, please don't send me away. And so this also kind of highlights this sort of deep-seated fear of abandonment in these children, particularly those who are being adopted out of the foster care system. So we know there's a lot of attachment and things like that there. But our caregivers saw that too, and they were very protective of that. The impacts on the families, each family had a very unique story. So we're talking about a very heterogeneous population here of families. But some of the common threads was our caregivers and their families were living in this prolonged crisis and described it. And when they were describing how they were managing it, we were hearing symptoms of traumatic stress, PTSD, whether they had the diagnosis or, our research team is comprised of a nurse and social workers. So we recognize those symptoms when we see them, and they were very present. Our caregivers were managing in kind of a state of hypervigilance. They had to keep eyes on their children 24/7. That included night watches. They took measures to secure their home, lock doors, windows, refrigerators. So that some of these things might sound pretty extreme, but if you hear their stories and you just listen and put yourself in their shoes, it's not, they were just doing what they needed to do to manage any level of safety in the home. Our caregivers used the word prison. So they described their home life as feeling like living in a prison. Multiple of them said that in separate interviews. Increasingly, the families responded by isolating themselves from family and friends because they couldn't take the child to family events or out to places to meet up with friends. That always resulted in some sort of meltdown. They also described marital strain. In some cases, marriages did not make it through the strain of the experience, and also the impacts on the other children in the home who were showing signs of anxiety and PTSD. So some pretty severe impacts on families. The theme of stigma really starts here. And we'll see it kind of continues through every phase. But during this phase, the stigma was more experienced in these social spaces, people kind of judging the child's behavior, maybe judging their parenting because they don't have the window into their reality. And this is stuff that looking from the outside in is really hard to understand and fully comprehend. So there again, families found themselves withdrawing to, first and foremost, to maintain safety, but also it just became increasingly unpleasant because of, the interaction, that feeling of not being understood. We did hear from some providers when it came to service seeking, there was the sense that families were not seeking out services soon enough. They were waiting until they were in crisis. And while I think that's probably true for some, in this sample, that did not line up with their descriptions of their experiences. Our caregivers recognized that something was off right away, starting with kind of the nature and severity of children when they were in early childhood having tantrums. These were tantrums that were much more kind of severe than typical and lasting longer. And they sought out services early on, starting, of course, with the community-based services. And this is really where we start to see the system is kind of starting to fail them, right? And that fight for help, it begins right here. They tried pediatricians, psychiatrists, teachers, therapists. They worked with crisis teams, law enforcement. Most of our kids had at least one Baker Act, some of them several. So they were trying to do what they could to help the child. We are admittedly going to paint kind of a bleak picture here. So I want to just highlight that what also came through, so this doesn't get totally overshadowed, is that also sort of embedded in these experiences of these families were providers who really stood alongside the families and did everything that they could to try to help them. Many of our caregivers were able to mention a person by name, a therapist, doctor, teacher, or somebody who did everything they could to help and really stood by them through the experience. So there is that piece of it. But then going back to their process of trying to seek out services, we found that they encountered a lot of gaps in services, including, in the cities like Tallahassee, especially when it comes to providers that accept Medicaid. We know this as a field. We have some serious service deserts, right? There's a lack of community services. And when you get into those more rural areas, they almost become non-existent. There really is a lack of respite that could have been a big source of support for some of these families, but it's just hard to get to or doesn't exist. That lack of services creates inconsistencies in how children are receiving therapies, the behavioral interventions, as does a high rate of turnover. And there can also be really long wait list. Funding, this is a challenge also that kind of threads throughout the journey. Getting funding was challenging. Almost half of our families had adopted out of the foster care system. They were eligible for post-adoption services, but they didn't know about them, or they faced some barriers with accessing those services. Of the families, all of them were able to get some level of service, but what they found was they weren't very effective at really addressing the children's needs. So we find that current community-based services are just not designed to address high acuity or those complex needs. We might have pockets of providers who are really trained in that, but as of now, it's just not readily accessible, and our families kind of spoke to that. And speaking to that misalignment here, we have a quote from an adoptive parent. This is reflecting on a situation where he had with his adoptive son. He was having an explosive episode and threatening violence. The father responded by calling law enforcement to intervene after he couldn't manage it himself. Law enforcement took nearly 2 hours to get there, and they came with somebody from the local CAT team. And the father says, so this girl show up. She went into the room and talked to the child, and she came out and told the sheriff that she gave the child 101 positive things to say about himself. And I just looked at her and said, you're kidding me, right? Because that's the box they work within. That's how they're trained. They're not really trained to work with kids who have these deep-seated trauma-based issues. And our providers, so moving to there, we spoke with, they too recognize the challenges in terms of the level of severity of children's behaviors, the hardships that the families were facing, particularly with accessing reliable, consistent services. And providers really expressed in various ways wanting to help families, but feeling somewhat limited in their role, in their specific role, in their ability to do that. Okay, moving to the next phase. So in this phase, this is where our caregivers are actively seeking out a residential placement. And we want to start by talking about kind of what led to that decision, sort of the precipitating event. All of the families had exhausted community-based resources. They had followed the kind of the crisis tiered model where that is generally how we approach accessing residential care, right? You have to fail up. You have to show first that those lower level services are not effective. And so they did that. But that final decision, some caregivers described it as a kind of a slow build of just increasingly recognizing that they couldn't manage it anymore. They were not able to keep the child or their family safe. They needed help. For others, it was a specific event. One child set the family's house on fire. Another brought a shank to school with the intention of physically assaulting another child. So what did that process of seeking residential care look like? The caregivers reported kind of figuring it out as they went along. There was a lot of self-reliance here, some heavy advocacy on the part of the caregiver. To find placements, they did Google searches, they used their professional, resources, but they found it hard to first of all, locate placements. There wasn't sort of an accessible list or database that they could go to that was publicly accessible. The options, TRC placement options, are limited in the state. And in addition to that, our caregivers found when placements were found, oftentimes their children weren't meeting that placement criteria. So they were either too aggressive, IQ was too low, IQ was too high, body mass index was too low or too high. So there was oftentimes some reason for denial related to them not meeting the criteria. They also ran into financial barriers. So residential care is one of the most costly interventions. By and large, most residential placements are covered by Medicaid, and this is because families, either their insurance won't cover it, or you really can't fund, most families cannot fund these placements out of pocket. So our caregivers applied for support through either the disability or the dependency system. And really, with the dependency system, how they interacted with that is, some of our caregivers went as far as to call in a report on themselves in order to have the child welfare system open up a case so they could access Medicaid. Again, I mentioned the stigma theme. It kind of carries through the whole process. And now in this phase, where our caregivers are talking about experiencing stigma from some providers in those encounters. And so here's a caregiver. She says, providers, counselors, and people who've not walked this walk are very quick to blame the adoptive parent. You just didn't care about the kid enough. You didn't make a real commitment. You're giving up on them, right? And so that was part of their experience with the care seeking process. The theme of gatekeeping is really a reflection of a complex systems issue, right? Both in terms of what's leading to what we're describing right now, or what I'm about to describe, that difficulty of accessing services, but also how we fix it. So now, just to kind of set the context, our caregivers are now actively seeking support from either the dependency or the disability system to get residential care. In their journey, they're fully in the weeds here. So think about that. They've already been in this fight to get the community-based services, which from a policy standpoint, our systems have kind of pushed those, right, to try to make them steer families toward that. But now they're trying to access the higher level services, residential care, which, going back to policy, our system has kind of pulled that and tried to reduce utilization. And so they were already experiencing issues with accessing supports, and now those issues are even more exacerbated because of the level of care they're trying to access. Our caregivers reported, in kind of their circles of expect their initial applications to be denied. Oftentimes denials were on the basis of there not being enough evidence of a crisis. So maybe they had several Baker Acts, but the parent didn't have the documentation for that. And then they would have to appeal, sometimes multiple times. Our caregivers found that appeals process incredibly intimidating, and they just weren't prepared for it. Many times they found themselves caught between the two systems, kind of being bounced back and forth. And in the midst of all this, our parents struggled with the limited communication. One parent said it felt like being involved in this secretive internal process. And another spoke to the timeline for decision-making. She said they have 45 days for a crisis decision. If I'm in a crisis, it means I need help immediately. My house is burning down. Our providers also offered some great insights to this phase of the process. We talked with them about what that process of seeking out a residential placement looks like. Depending on who we talked to, there were differences in how it was approached, sort of in some of the details, but generally we could identify the steps that look like what's shown there on the chart on the screen. So it's referral, review, evaluation, and then if residential care is deemed necessary, then the search begins. And this process can take a little bit of time. And especially if you're denied the first time, then you have to kind of start over. Common challenges that our providers really spoke to were in situations where a family went through this review process and residential care was deemed necessary. One provider said they automatically look out of state because they know it's going to be challenging to find something in state. Another speaking to some frustration because of them having resources to help families, but there was the challenge was getting that information out so that the families know they're there. And she said, no one knows we're here or who we are. Another provider spoke back to that issue of children being denied based on placement criteria. They said they'll be denied by a lot of places because they're too aggressive, but then, they're too aggressive for the lower levels of care as well. So that makes it very difficult. So I think between the two, caregivers and providers, we're seeing a lot of recognition and agreement in some of what the challenges are during this phase as well. Okay, we also wanted to share some selected case examples. And just like in any quotes that I'm giving, the names have been changed and some of the details to protect the confidentiality of our participants. But here we have the Mason family. Nancy Mason's 16-year-old daughter, Susan, has severe OCD that's worsened pretty dramatically over the last few years, leaving Susan nearly incapacitated. She spends the bulk of her waking hours engaging in extreme rituals, obsessive hand washing, and hygiene practices. Nancy is now her full-time caregiver, manages all of her daily tasks, including feeding her. Nancy sought out residential due to Susan's severe mental health issues, but one of the things that has prevented her from being admitted is her low weight. They faced repeated denials from multiple programs, also due to the severity of Susan's symptoms. They couldn't find a good fit, or cost was just insurmountable for them. Nancy's exhausted local resources, including paying out of pocket for therapy. The toll on Nancy has been pretty immense, including on her marriage, on her daughters. Her other children in the home have been impacted by this. And currently, at the time of the interview, Nancy was still currently seeking out placement. So Susan had not yet been found a residential placement that would accept her. Okay, let's go back to our framework and talk about the second phase. Let's see here. Okay, so for some of our families, as you could see, they did successfully find residential care. The first step of that is, once a placement is found, transitioning the child into care. And they felt like the transition process was, let me back up just a little bit. First, let's talk about how they got the child into residential care. Sorry about that. So among those families who found residential care, there were some different pathways that they were able to do that by. Most of the time, it wasn't based on the best fit. It was based on the bed that was available. And this, again, goes back to having limited facilities. Sometimes it was families were approved for Medicaid, and then they secured a placement that way. Other times they paid out of pocket. We have a quote on the slide that shows from a family who's paying $5,000 a month for their adopted son to be in a residential program. And this family just happened to have some assets. They had a rental property they could sell to fund that placement. In other cases, that residential program was secured, or that placement was secured through lockout. So this is where the caregiver refuses to pick up a child from a hospital or a shelter as a way to force the state to open a case. And once that happens, Medicaid will kick in and cover that placement. Once that placement was secured, the time to placement ranged from 1 week, so it tended to be shorter if that placement occurred as a result of a lockout, to up to 4 months. Parents were able to visit facilities in some cases, but a lot of times those facilities were located 2 or more hours away from where the family lived, so that made it a little bit difficult. A typical transition from the parent's perspective looked like receiving a list of what to bring, maybe a packet, but not really much more beyond that. Communication of what to expect or some form of orientation was described by one caregiver as leaving a little bit to be desired. Another caregiver, really reflected on this being a very emotional experience. And she said it was a whole bundle of everything: nervous, anxious, relieved. It was a roller coaster. And then that theme of parental guilt was very much a part of this. Robynn mentioned it in the beginning. Asking yourself, am I a horrible parent, right? There was a lot of fear in our parents that placing their child in residential care was going to be perceived as the child as they were abandoning them. Okay, during the placement experience, then, from the caregiver's point of view, there's three themes. One, after a period of time, they grappled with a lot of guilt and questioning themselves early on, but after a period of time, all of our parents realized this really was the best decision for the child. Something they really struggled with during the placement was kind of letting go of the reins and learning to co-parent with the staff, because they were used to having hyper control over everything. That was kind of the entirety of their lives. In terms of thinking about the better placement experiences, our caregivers said, and this is just good logic, when that program and the services they offered were better fit to the child's needs, they had a better experience, and they saw the child's improvement more. They were able to talk about that more readily. The other thing that was a big factor was consistent communication from the residential program and the parent. So family engagement really factored in to a better experience. Funding concerns were big here. A lot of families feared being dropped. This from Medicaid, or families who were paying out of pocket were, constantly stressing about how they were going to be able to continue to fund that placement. The impacts on the child and family. So starting with the child, most of our children, all the caregivers described their child as their behaviors stabilizing, right? Even in situations where the child's behavior didn't necessarily improve, it was still being managed in a more controlled environment versus in the home where it was creating chaos and constant safety issues. So even that was better. This is a quote from a mother who observed the impact on her child. So she says, the first week or two, I was getting a text message every day on how he was doing with a picture to let me know he was okay. But the first picture I got where he was smiling, I lost it. I'm like, he is really happy. He doesn't look like a prisoner anymore. And that was an important point that a lot of our other caregivers kind of connected with, right? That process of getting them into residential placement, allowing them to move out of that full-time crisis manager mode, actually allowed them to then just be a parent to that child. And they saw their relationships with their children kind of evolve and deepen. During the precursors period, we saw that, there was a lot going in the home, and these things were having their impacts on the family as well. We talked about marital strain and the caregiver experiencing depression and anxiety, but there were the other children in the home as well, right? And they were impacted, and caregivers spoke to that. So, the siblings in the home also couldn't live a normal life. They couldn't invite friends over. They couldn't have sleepovers. And a lot of times, they just couldn't do the normal things that families could do, like have family vacations, things like that. It was interesting that we heard caregivers describe what also sounded like sibling guilt, right? One caregiver was talking about her son after his older brother was placed. And he said, I love my brother, but I don't want him to come home. Okay, so then moving to providers. The providers felt experiences in residential care from their point of view varied, right? Ranging from they actually seeing kids make meaningful improvements to some kids becoming what they described as institutionalized. One point of major convergence, and we heard it from a lot of providers, was when families can be involved. When that is in place, we see better experiences and outcomes. So both caregivers and providers agreed with that. I do have another case example, but I am seeing we're bumping up against our time. So I'm going to skip this one, but our slides are available for those of you who are interested in them. We're happy to share that. Let's move into our last phase. This is post-placement, and it starts with that period of time where a child is transitioning and then discharged from residential care. Reasons for discharge, there's a few of them. Some of them were great. The child had completed the program, or maybe they aged out, right? Other discharges were due to funding being discontinued. The justification that was described to us by the funding entity was that the child had reached maximum benefit. So somewhere along the way, the case was reviewed and somebody had decided that. And even if that was not necessarily agreed upon by the treatment team and the caregiver, that decision was made. And here's an example of where a quote from when caregiver had that experience. So every other time except this past time, it was Medicaid. We had to battle beyond battle to get that. Medicaid never wants to pay for it, and then they want to discharge them entirely too soon before they're ready, and then you end up back, which is why we were there 3 different times at that point. Other reasons that children were discharged was the program may have reached a point where they'd had the child in care for a long time, and they came to the conclusion that we've really, as a program, maxed out what we're going to be able to do for that child. Our providers described that practice of transition and discharge is kind of being unpredictable and challenging, echoing a lot of what our caregivers said. So one provider described the issues with service disruptions, right? So you can see it there on the slide. They have services, but then they're sent to another placement. They have to start all over again, and the child might not have a consistent therapist that can help see them through that process. So this kind of placement disruption requires them to rebuild that rapport, retell their story, and go through their trauma again. Another provider said, I don't think the system is really set up to benefit these families. Okay, so following residential care, outcomes varied. So some children returned home. We found that some of our caregivers who, prior to the child coming home, and even in cases where we listened to how the step down process occurred in our residential programs, we're doing all the right things. So there was home visits, and kind of a tiered approach to getting them back. Caregivers often felt a little bit less prepared than expected. Other children went on to adult group homes, long-term group homes, and some, of course, are still in awaiting residential care. When asked about the future, our caregivers, reflected on having a lot of uncertainty. They were feeling like their journey's not over. They're not really out of the woods yet. And our providers offered some overall thoughts on the process, right? Recognizing that the right residential care can really be helpful to some kids. Another provider was speaking to a greater need for coordination within and across systems. And I think this is a really important point, and they just say it very plain and simply. Everybody needs to get together in order for this to work. And I think that is about as right on point as it gets. And closing out our interviews, we asked our caregivers to describe their experience. And you can see here, frustrating, lonely, lack of guidance. It's hard, steep learning curve, right? So it really speaks to some real gaps in supports, resulting in a highly difficult, prolonged process of getting the right level of services to address these children's needs. All right, going back to the goal of this project, first it was to map the caregiver's experience with seeking residential care, ideally to use that information that we're learning from our caregivers from their perspective, but also the providers, to identify hypothesized impact points that, based on what we're hearing, where those gaps are and where there are needs, what are things that we could do, tying it back to a specific phase, right? So that's when that intervention is needed, right? So I'm just going to give you a couple examples here, starting with the precursor phase. We identified there were gaps in community-based services. And obviously this is not exhaustive, and these potential impact points don't solve all of the problems, but they may help. So we identify gaps in community-based services, a lack of maybe what caregivers provide as perceived as appropriate responses from the crisis response teams. And so one option might be to establish mobile crisis teams with providers who are specifically trained, and there are evidence-based trainings to work with high acuity youth. Florida has some of the pieces in place. They already have CAT teams, and so perhaps it's focusing in more on advanced specialized trainings for some of those providers beyond what we're seeing now. Another option might be offering, so caregivers were reporting isolation, right? A lot of our response focuses on getting the child services, but what came through loud and clear is that our parents need support too. So caregivers reported that feeling of isolation, right? And that's starting early on. So one option to address that might be providing family peer support program and connecting parents with those family peer support specialists early on so that they can work alongside the parent, drawing upon their lived experience and offering kind of that non-judgmental support. Okay, I'm just going to go through one more, jumping to the admission and placement phase. So one of the things that we know is true is that we just lack a sufficient number of units or facilities that can accept youth with high acuity needs. And so the need is definitely outweighing our capacity, right? And so it may be that rather than starting new programs, that instead we identify existing facilities where we can set up some and pilot high acuity units that have staff that are specially trained to work with those sorts of youth. All right, so this is really all about how can we kind of channel the resources that we have, bring in resources that are needed to help children get effective care in a way where they don't have to go through this prolonged process and endure multiple traumas as a result. Okay, I'm going to hand things back to Robyn.
I apologize. I'm muted. Okay. So some of the next steps we're working on, we are working with FICW. They've asked us to do work on this high acuity youth comprehensive project. Some of the things that are included in that is we're going to be doing an interactive map. So you can look up resource that'll include maternity homes also. We're going to do exploratory studies on stakeholder perspectives and quality. We're working now on a high acuity work group with stakeholders across the state. Our first meeting is going to be October 8th on that. I'm really looking forward to that. And then we'll be doing some more research on pilot residential care staff training and developing training for that. Also, one of the things that was barely touched on in this, and I think is a very important aspect of this, is the sibling study, because of the way this is affecting these children that are living with, sometimes 3, 4, 5 siblings are coming out of this house with their own mental health issues after living in this really intense situation. And we would like to do a study on that, focus on caregivers of autistic children with high acuity needs. One of the things we would like to do is a study. We're waiting to hear back. I think in December is when we hear back if we can get the funding for this. It'll be Florida versus Massachusetts and the resources available for these autistic children. I've already started a caregiver support group. If you guys are interested in my contact name, it's for the higher acuity. It's just to get rid of the caregiver isolation. My contact information will be in one of these slides. Please reach out to me and I'll be happy to send the link for a caregiver to sign up. It's just caregivers coming together, supporting each other, and in positive ways, maybe sharing some ideas on how we did things, especially for those who are just in the process of seeking. And then next, I think we open up for any questions and comments next. Yep. If there's any questions and comments, please feel free to ask.
Yes, I put a little message in the chat for everyone because I know we're coming up short on time. So if anyone wants to put anything in the chat or use the raise hand feature, we probably have about 30 seconds to a minute. Anything in the chat, we will download it and we can share it with Shamra and Robyn. Comments too, it doesn't just have to be questions. Susan, I think I see. Can you take her mute off, Juliana? I don't have that option.
I had. Hold on.
Yes. Am I unmuted, I think?
Yes.
I just wondered what the youngest or what ages. Most of the people you've been talking about were in, their teens. I wondered what's the youngest kid you put into residential care?
Yeah, in this sample, Robyn, I'm gonna say 10.
Yeah.
Is that sound about right? Yeah. We don't have a lot of, that's another common reason for denials, especially if the behaviors are coming from kids who are under a little younger like that. We don't have a lot of programs that will accept younger children in the state.
Okay. Thank you.
Thank you for your question.
Mm-hmm. It was very good, though. Thank you very much. Very helpful.
Thank you so much.
So I do see some thank yous and good information comments. I really appreciate all of you for joining and listening and being actively engaged. Because we are a research institute, we always want to find out how we did. So in the chat is our post-webinar Qualtrics survey. If you have a moment, it should only take 1 to 2 minutes. We are just asking, how was the experience for you? Was the content good? Did you learn what you wanted to learn? Just so we can continue to do these and tailor it to the to what you all are interested in learning about. So as I said, this was recorded. Shamra has slides. We will package that up real nicely for everyone and distribute it hopefully in the next couple of days. And to stay aware of what's going on, please follow us on social media or sign up for our newsletters. We're constantly coming up with new and creative ways to get information out and to teach everyone about all the good stuff that's going on. So thank you, Shamra. Thank you, Robyn. Wonderful presentation as always. And
yes, thank you.
We will see you all at the next webinar.
Thank you so much.
You're welcome.
There's a question. Will the package information that's going out include contact info for the caregiver group?
Yes. Yeah, in the slide, she can contact me on Robynn Baker. It's my information. It should be on the next slide, I think. We'll have all the information. She can reach out to me. I don't send the link to the group. I make them sign up in using Microsoft Forms because I want to keep them confidential. I don't just want a random link going out to everybody on Facebook or whatever, so that these parents feel, or the caregivers feel safe in these meetings. So if the person will reach out to me, I can send a flyer so they can sign up.
All right. Have a great afternoon, everyone.
Thank you, everyone.